This is part of the follow-up discussion I spoke of earlier this week relative to the issues concerning non-emergency Medicaid transportation, NEMT, that took place based upon a number of meetings that were held here in Washington last week. I was pleased to participate in several of these discussions, some with the American Medical Association, some with AARP, some with Project Action, some with Senator Menendez, and I was privileged to have a long and lengthy meeting with Fran Crystal, who is the director of the CMS Medicaid Transportation Program in Baltimore. The bottom line of many of these discussions concerned the introduction of aggressive managed care operations in Medicaid. As you know, California is the most recent state to adopt putting their Medicaid programs into a more insurance-like model than they've used in the past. As we go forward over the next several years and the Medicaid program is expanded under the Affordable Health Care Act to include more and more working people, Medicaid will resemble more and more a typical kind of insurance program and lose a lot of its identity that it has today as more of a government program. States are choosing these options, as we explained in some articles we sent last year, because they don't have the capacity to administer insurance-like programs, and they don't have the efficiencies necessary to manage such large numbers of people. The thing about Medicaid that is different, though, from other insurance programs is that it has the transportation benefit. Our association worked hard to preserve and protect this benefit, especially over the last 10 years, but especially in the last 4 or 5 years of the Bush administration when they sought to remove it. Today, there is broad acceptance, I believe, at all levels of Congress, the Senate, and at CMS that Medicaid recipients have to have access to health care, and only good transportation is a way of providing the assurance that they can be served. In looking at the future, managed care, as it's being developed, says to insurance companies that we will only pay you for providing care if the services that you provide are successful and that they solve a healthcare problem or address a healthcare need of some participating insured Medicaid individual. This means that Medicaid patients will be into a managed care environment where they can't just self-select the services they need or the trips they need. They're going to have to be coordinated through an insurance company, not unlike the kind of relationships that some of us have in HMOs or some other kind of preferred provider organization. As part of that process, those insurance companies will also ultimately control the transportation benefit. They will either administer it themselves or they will administer it through a medical transportation managed care company, which is a term that is being used by people like Logisticare and others now to describe their work. In some respects, NEMT won't be much different than radiology, where an insurance company provides x-rays, but it doesn't run the x-ray company. It turns to a radiology group to provide that services. In some respects, they will turn to a broker, as we know them today, or other entities to be created to provide that linkage to transportation. In California, where a significant portion of the overall Medicaid population has been moved to an insurance program, it is no surprise that the insurance company that's managing the largest pool of Medicaid patients in the nation has turned to a broker, in this case Logisticare, to manage the transportation portion. That being the case, the issue then is how will community and public transportation play its historic and continuing historic role in providing transportation. This is complicated in some respects by this insurance approach and a much harder and more proof-driven system to get health care that will emerge, but it's also made a little bit more difficult because there will be a larger number of people covered more than ever before, and that almost all of the secondary services will be done in the outpatient medical treatment environment. Last week, Project Action and AARP released some research they did about the kinds of people and the services currently being provided by NEMT. As it looks from the research, a significant portion, 70%, of all NEMT services are directed toward dialysis, and a significant portion for behavioral health. As we look at the information that is developed when one looks at the kind of treatments and chronic illnesses that are out there, we see that those kinds of individuals will tend to dominate the Medicaid transportation population, just like we described in the recent article that we published on dialysis transportation. So people who will be harder to serve will need more intensive service, and in the case of dialysis, they will need more one-on-one trips to cope with their medical treatment situation. This comes at a time when all governments in our country are under financial stress. As I said at the AARP meeting when I spoke, it really shouldn't be surprising to us that because of the financial conditions in the states and the growing numbers of people who need transportation, that there would not be significant pressure by the states to lower the costs that are being paid for medical transportation. There is no guarantee that that trend will change. And what I think I've learned from our discussions, especially with CMS, is that they are continuing to seek a significantly lower transportation reimbursement rate throughout the nation. This is also typical of the situation with doctor payments and hospital payments, significantly lower than the real cost and significantly lower than the average cost. So our members and our community are forced to participate in a Medicaid option for transportation that is more and more competitive as these intermediaries and insurance companies seek to respond to a state's growing desire to lower the cost for treatment. What we do about this scenario of lower cost is our challenge. The arguments that have been made in the past about coordination and cost sharing aren't really working when a state is able, through a broker, to bring in competitors who will provide this service cheaper than the cost that we are able to provide it for in the current operating environment. The significant challenge for community and public transportation in the next several years will be the issue of affordability and competitiveness. How we can move our way of providing service to a more price-driven option that will result in lowering the cost. This isn't really an impossibility for us because at the current level of service, we do that all the time. We do it by grouping people together and taking them to different destinations. The problem is occurring because the population that needs our service and has the greatest demand in Medicaid is no longer being able to be pulled together or grouped in the way we've done in the past. That's the single biggest issue, and that's what's in our dialysis article, which I urge you to go and read. That is the critical factor of the future of our program. People that need more intensive services and at a time when we're pushing cost containment. How we deal with this will be the subject of my next message and some ideas on it. But clearly we're going to have to come out with some new and innovative ways or some different political decisions to make our work the key component of linking people with health care in the year ahead. Thanks for now, and I'll be back shortly.